to lose weight by any means. She lose weight by any means, even use of heavy exercise, and she, yeah, literally, she didn't eat. She didn't eat anything. And that's why she maybe go to starvation ketosis. She, days after days and months, she didn't eat. She's having a problem which is called body dysmorphic disorder. What is the body dysmorphic disorder? Continuous mirror checking of herself. She's checking of herself, and she, like this picture, she sees herself like this. She sees herself like to be fat. And that's why she's going to lose weight by any means. She has the concept of being fat in spite or despite of being very thin like this in actual life. And that's why this girl may be subjected to stress fracture and comes to you in the ER with an osteoporosis in a very young age. This is 15 years old with an osteoporosis. Yes, because she has a starvation ketosis, because she didn't eat anything. There is hypocalcemia. There is a stress fracture because of the heavy exercise. And that's why she comes to you in the ER with osteoporosis in a young age, with a stress fracture in a young age. That's one. The other thing, when she tries to consume, anything, she's being used of what? Induced vomiting to herself. Induced vomiting to herself, putting her fingers in her mouth like this. Russell sign. Russell sign, it's the teeth. Again, it's this finger. Causes signs, which called Russell sign. And that's why she has electrolyte derangement. The electrolyte derangement may be the same cause that may cause this case hypokalemic cardiac arrhythmia. And that's why she may arrested because of hypokalemia. Okay, that's second. The third thing, because of she didn't eat, what do you think about the hypothalamic hypopituitary axis? The hypothalamic hypopituitary axis, there is hypogonadotropic, hypothalamic circadian rhythm will be low. And you know that the hypothalamus, GnRH, gonadotropin releasing hormone, which GnRH goes to, from the pituitary, FSH-LH, which goes to the ovaries to secrete what? Estrogen and progesterone. And that's why this patient, when you block this circadian rhythm, what happened to this patient? She comes to you in the ER with amenorrhea. And that's why you will see this patient in amenorrhea, doctor. You will see this patient coming to amenorrhea because there is impaired insight of her problem. She didn't know that she had any psychiatric problem. And that's why these patients come to you with the complication, comes to you with the stress fracture, with the amenorrhea, with hypokalemia. And she didn't complain that she didn't eat. You will find out as a doctor that she didn't eat. One of the MCQs that comes to the recalls, what do you think, doctor, about the hormonal arrangement with this patient? She has had, what do you think about insulin? Insulin is low for this patient. What do you think about growth hormone, which counteract the insulin? It will be high. What do you think about cortisol, which is the stress hormone? Will be high. She's in a stress. She's in a continuous stress, doctor. And that's why. That's coming to the MCQ in recalls at once. 23 years old female patient, recently diagnosed with anorexia nervosa, which was following, is not recognized as a feature, is not recognized as a feature. What do you think? Hypokalemia? No. She has hypokalemia. Low FSH? Yes. She has low FSH. Impaired glucose tolerance? Yes, because the insulin is low and the glucose, she had no glucose. And what do you think about the growth hormone? Oh, gee. The anorexia nervosa has high growth hormone, not a low growth hormone, because it's counteracting the insulin. And that's why this is the MCQ right answer. Okay? Something else. Yes, doctor, yes. We can get the questions in the by the end of the topic, please.
I'm really
because
sorry.
of the interruption. Okay. Okay. What do you think about this? Anorexia nervosa, Russell sign, on their hand. Other thing, refeeding syndrome. Refeeding syndrome. What's meant by the refeeding syndrome, doctor? When you get this patient admitted to the hospital, you try to feed her. When you try to feed her, you, as a doctor, you write in the chart like this, feed her with the diet and give her fluids, normal saline, and the glucose, and blah, blah, blah. And when she admitted in your hospital, the nurse, you will be panic. If the nurse coming to you and said, doctor, the patient, when we start to feed her, she complained of shock, then arrested. Oh, arrested? Why? When you start to feed this patient improperly, she might arrest. This is called refeeding syndrome. What's meant by refeeding syndrome? This is a very high yield common topic on concept in the PLAB exam. The refeeding syndrome means that when this patient in the starvation, what happened in the tissue and the cells? The calcium, the magnesium, the potassium, the phosphorus coming from the cells to the serum like this. And the serum will be full in the potassium, calcium, magnesium, phosphorus from the cells at the tissue level. When you start to feed these patients, what do you think about the cells? The stores of the cells that being depleted will take her stores again, will take the calcium, the magnesium, the phosphorus from the serum again, and that's make a drop in the potassium abruptly when you start improper feeding without electrolyte monitoring for this patient. And that's why when you try to feed the case of anorexia nervosa, try to give her the electrolyte replacement with close monitoring and low sips of diet because of refeeding syndrome, okay? And close monitoring of her electrolytes. That's one issue. Other issues regarding the PLAB concepts of the grades of anorexia, mild, moderate, or severe anorexia nervosa. The mild, moderate, and severe anorexia nervosa are being tested according to body mass index. You know that the normal body mass index of the patients of anorexia nervosa, the normal body mass index is between 17.5 to 24.5. Whenever you see a patient above 17.5 body mass index, you will see this patient above 17.5 body mass index without complications. Without complications, I meant without hypokalemia, without hypocalcemia, without shock state, blood pressure is above 90/60. And that's why she without complication and body mass index is okay, above 17.5, this is mild anorexia. Mild anorexia, you will admit this patient? No, you will not admit this patient. You will encourage the use of self-help books and diaries for this patient and discharge her, okay? And you will sit with the patient and will do some cognition behavior therapy for this patient and will send her home with a diary, food diary, but will not admit her. What do you think about the moderate anorexia nervosa? Moderate anorexia nervosa between 15 to 17.5 body mass index. You will see in the case if there is any complications regarding the blood pressure or electrolyte derangement. If I didn't see any complication like this case, anorexia nervosa, blood pressure 95 or 65, and I have the body mass index between 15 to 17.5 without any complication, then I will admit her. But in the eating disorder unit, okay? The other case, the severe anorexia case, that's the patient below 15. Below 15 body mass index, this patient will be admitted not in the eating disorder unit, she will be admitted in the medical unit. Why? Because this is a sign of starvation, okay? whenever you see a patient, even in the above body mass index, but with complication, you will admit her, but not in the eating, in the medical unit as well. You mean, doctor, that if I see a mild case of anorexia nervosa with hypokalemia, I will admit this patient in the medical unit? Yes, in the medical unit, not in the eating unit. Whenever any issues in the patient being medical, I will admit the patient in the medical unit, not in the eating disorder unit. When I will admit this patient compulsory, against her will, when I do that, I will do that if the patient refuses the medication, refuses the admission. Like this question, 16 years old female patients brought to you were falling down to the shopping mall. She's brought to you by her mother. Body mass index is 18. This is mild case of anorexia nervosa. But what do you think about the glucose level by millimole? It's very low. So I have to admit her in the medical unit. She refuses, then I will go for compulsory admission. Why I will go for compulsory admission for this case? Why I will do this? Because this patient have impaired insight, doctor. Impaired insight. Because this patient incompetent. Oh, this patient incompetent? Yes. This patient didn't know that she had any problem regarding the mental illness, psychiatric illness. You will admit her against her will. Because in the ethics lecture, we will go and discuss that you will have to do anything to the patient, but with his permission. What's meant by the will of the patient, the autonomy chapter, the autonomy topic in the ethics. You will do anything to the patient, even it against her beneficial issues. If the patient didn't want to get any blood transfusion, if the patient refuses to get any blood transfusion, and the hemoglobin level is 5 after an RTA, road traffic accident, and she write a consent that she refuses the blood transfusion, you will do what? You will infuse to her blood, or you will have to admire and respect her wishes, even if it's against her own health. Yes, this is called autonomy. Because this patient is competent, okay, but this patient is incompetent. This patient is not competent, and that's why you will admit her compulsory against her will. That's clear, doctor? That's clear issues, doctor? Okay? This is regarding anorexia nervosa. But what is the difference between the anorexia nervosa and the bulimia nervosa? What's the main difference here? The main difference here regarding both is the body mass index. The body mass index and also the concept. The bulimia nervosa, this is one having a risk factor of the binge eating families. It's born in an obese families, and she thinks that to be beauty, she had not to get obese like her father and mother. And whenever she eats, she feeling guilty. And that's why she are doing to herself vomiting. She are abusing laxatives. Yes. But she has an insight. She has insight, not impaired insight like this. No, she has insight. She knows that whenever I eat, I felt guilt. I has to go to the bathroom to induce vomiting to myself. And that's why she may complaining of Russell sign or complication of laxative abuses. What's the complication, the bulimia nervosa for laxative abuses? Hyponatremia, hypokalemia. Hyponatremia and hypokalemia in the bulimia nervosa. Hypokalemia and hyponatremia in the bulimia nervosa meant by one of the recall MCQs here. How to know that this case abuses laxatives? When there is increased GI losses of potassium due to laxatives, the renal conservation of potassium increases, and that's why you may find a low urinary potassium for this case, which is an indicative of a laxative abuse for the case of the bulimia nervosa. This is a tricky question regarding what's the investigation to do to know that this case is abusing laxatives. You will test the potassium in urine. In case of the bulimia nervosa, if she abuses laxative, you will find low potassium in urine, which mean that she abuses laxative. Something else. What is the first treatment in bulimia? Cognitive behavior therapy. History because of depression and feeling guilty. Okay? This is not a kind of case of body dysmorphic disorder like the anorexia. Anorexia is mirror checking of herself, body dysmorphic disorder, but the bulimia, no. And that's why whenever you see in the question feels guilty in a body mass index above 17.5, this is bulimia, not anorexia. This is bulimia nervosa, not anorexia. Because of the induction of vomiting, you might see parotid swelling because of the salivary gland over-functioning because of the induction of vomiting. And this is a bulimia nervosa case, not anorexia nervosa case as well. That's the main difference between both. That's clear, doctors? Any question regarding this topic?
Yes, doctor. أنا كنت عايزة أسأل عشان البوتاسيوم في البوليميا نرفوزا.